Okay, so this is another station from the Salam Mox, which is pulmonary edema. So this time is a 70-year-old post-operative male patient. Patient has received crystalloids plus colloids, about 7 liter, 4 liter of them are normal saline. Now he is tachycardic, hypertensive, desaturated, and oliguric. Fluid chart plus vital chart inside the station. Okay. So you will be given a patient a scenario in which patient is given a huge amount of fluid, and now patient is hypertensive, desaturated, oliguric, tachycardic. You will be given the fluid charts, like they will show you these data and vitals as well. So these are what are the your expected physical findings: congested neck veins, puffiness of the face, lung crepitations, basal lung crepitations, especially confusion. Interpret this chest X-ray. So this is the chest X-ray. This is not a clear X-ray because this is. I will show the proper X-ray of pulmonary edema, bat wing appearance specifically. I will share the proper X-ray, so you will very easily appreciate pulmonary edema. Okay, so the pulmonary edema, loss of crepitation, cardiophrenic angle, and cardiomegaly. So here it is the cardiomegaly, and we have the loss of cardiophrenic angle. So this angle, yes, this angle with the cardiac and the diaphragm angle is lost. And there is pulmonary edema. We have these lines and bat wing appearance or butterfly shape appearance. Also, these are the findings. Okay, so this is your interpretation that it's this chest X shows pulmonary edema, loss of cardiophrenic angle, cardiomegaly. And what are the findings in the pulmonary edema? Alveolar edema, bat wing or butterfly appearance, curly B lines, cardiomegaly, dilated prominent upper lobe vessels. So why this patient is on a high risk of MI, decreased coronary arteries filling due to tachycardia. So you should know that the heart arteries, the coronary arteries, they fill with blood during diastole. So when there is tachycardia, so there will be no time for the proper perfusion or filling of the these coronary arteries. So automatically there will be ischemia of the heart muscles. So this can cause tachycardia, can cause MI. So this is the another question. Sometime they ask is the why or what is the reason for aortic stenosis to cause heart block. So we have the same, not the same, but the reason is that in aortic stenosis the perfusion or the heart contractility is reduced because of the hypertrophy of the ventricular hypertrophy. So the demand is also increased because the vessels are huge and the end diastolic volume is low, so there is less perfusion or filling of the coronary arteries, and the perfusion of the heart is not okay. Specifically, the since we have this SN node, which is going to the AV node here, so this will give us the Purkinje fibers to both the heart chambers, ventricles. So specifically, if there is ischemia of this AV node or the Purkinje fibers, so there will be block. There will be heart block. Okay. So okay, now moving into the next question. Why is there is a high risk? Because the coronary arteries fill. There will be no filling of the coronary arteries or no proper filling during tachycardia, which leads to decrease in diastolic time. Increased cardiac oxygen demand due to increased cardiac load, because there will be hypervolemia. The age of the patient is 70-year old, so there is high risk. What is the minimal urine output? In adults, the minimum acceptable urine output is 0.5 ml per kg per hour. So, can you explain why the patient is oliguric? The most common cause is due to physiological stress response to surgery in the first 24 to 38 hours. So, postoperatively, the body is under stress because of the surgery. Surgery is itself a stress. So, body secretes the stress hormones like cortisol, ADH, catecholamine. So, all these try to conserve body volume and body water. So, ADH will reabsorb cortisol as well, mineralocorticoids, and these catecholamine has no role, but the mineralocorticoids mainly, and this renin secretion will occur, aldosterone. So postoperatively, in the first 24 to 36 hours, there is a high chance that the body goes into hypervolemia. So that's why the most common cause is due to physiological stress response to surgery in the first 24 to 48 hours postoperatively. This is due to circulating glucocorticoids and mineralocorticoids inducing salt and water retention, plus the ADH as well. Surgical trauma and various anesthetic gases also stimulates the release of vasopressin from the posterior pituitary, stimulating the postoperative solute-free water retention. Congestive heart failure with low. Okay, so if there is hypervolemia, so hypervolemia, so there will be congestive heart failure, and it can also cause a decrease out cardiac output, and decreased cardiac output will decrease the renal perfusion, and so GFR as well. So there will be low urine output. Okay, explain what are the fluids given to this patient. So crystalloids and colloids. Amount of sodium in 0.9% saline is 150 millimole per liter. Amount of sodium in hot wine is 131. So the patient received a large amount of sodium, which will also attract water because it's a solute. How to manage fluid overload? This is critically ill surgical patient, so I will manage according to CRISP with ABCDE approach. Lies with I will also inform the intention therapy unit. Register, inform the consultant. Stop all IV fluids. Commence high flow oxygen IV furosemide. To induce diuresis. GTN infusion if systolic blood pressure is greater than 100. So this will improve the cardiac perfusion. Request chest X-ray, ABG, electrolytes, and ECG. Ventilatory support. Consider non-invasive ventilation in severe acute pulmonary edema, and CPAP prefer for cardiogenic pulmonary edema. So non-invasive. Consider non-invasive ventilation in severe acute pulmonary edema. CPAP is preferred. And then I will start the medical management. So also look for congestive cardiac failure, so to manage it timely. Give beta blockers. They are life-saving and improves mortality because they reduce heart rate, and so there will be less chance of congestive cardiac failure. Cardiac function will improve. This all comes then in the medical management. What is the rule of medical management? So preload reduction we use. Okay, so the heart has preload, and this is the afterload. Afterload we go outside, preload will come inside. So the heart has two things, preload and afterload. Okay, wait. So preload reduction, afterload reduction, and inotropic support. So inotropic support is by dobutamine, and wait, something is going on. Okay, So inotropic support is by dobutamine, dopamine, and afterload reduction is by AC inhibitor, enalapril or captopril, ARBs. Um, ACEs are angiotensin converting enzyme inhibitors, and ARB are angiotensin receptor blockers. Nitrates, diuretics, IV morphine sulfate. This will reduce these preload, so there will be less pressure on hot, and this will the rest will the AC inhibitors, and these will reduce the afterload. This will improve hot contractility and heart rate. Daily requirement of sodium is and potassium is sodium 1 to 2 milliequivalent per kg, and potassium is 0.5 to 1 milliequivalent per kg. What can be done to prevent okay what can be done to prevent this from happening again? Insert a CV line, center venous line, monitoring the center venous line, monitoring urine output, report to the hospital incident reporting system, better training of junior staff. Okay. Investigations for this patient is chest X-ray, ABG, electrolytes, and ECG. ECG in pulmonary edema. So tachycardia, deep Q waves, prolonged QRS complex, MI, arrhythmia, ventricular failure, all these can be shown by the ECG. And role of CPAP in pulmonary edema. So improves oxygenation. CPAP applies positive pressure to the lungs, keeping them open and prevent collapse. This increases the amount of oxygen that can enter the bloodstream. Reduces respiratory effect. The positive pressure helps to keep the airway open, making it easier for the patient to breathe. This can decrease the work of breathing and reduce fatigue. Decreases cardiac workload. By improving lung function, CPAP can help decrease the workload on the heart, which is often struggling to pump blood effectively in pulmonary edema. In this station, the examiner may ask the questions in other ways. Effects of pulmonary edema on heart circulation. So you can say that when there is pulmonary edema, we will have less oxygenation of the hemoglobin, and so there will be oral tissue ischemia, or you can say tissue will desaturate, and so the heart will try more to pump to increase the cardiac output. So there will be a high workload on the heart. Okay.